Good afternoon, everybody. So glad that you could join me today for our noon conference, and thank you for taking the time to join in and participate today. We'll be doing a few questions via poll EV, and as always, our echo primer through that as well. These things work best if you're on the web, but there will be a few questions where you can text in your answer as well. So let's get started. So today we will be talking through describing some various types of interstitial lung diseases, or ILDs. We'll be interpreting pulmonary function tests, and we'll understand the basics of ILD treatment, but won't go into a lot of details about that. Just as a reminder for poll EV, though, how to join will also appear with each question itself. So as we do, our first question will be our echo primer question. So far we've talked and looked at our subxiphoid view and then parasternal long view. Today we're looking at the apical 4-chamber view. And if you're on the web browser, you just click in the area that you think is the left atrium. Yes, looks like for those that are participating, we have a consensus on which chamber we think is the left atrium. And you guys are correct, so nice work. So let's go through what the rest of this image is showing us. Okay, so like I said, this is the apical 4-chamber view. To get this view, you'd put your probe on the patient's sort of left chest, somewhere in between their left nipple and the axillary line, and then you're looking towards sort of their mouth. And this is a difficult view to get at the beginning, but just rotate and pan and tilt your probe until you get this view. And when you find it, you'll see the interventricular septum here, the right atrium here, draining into the right ventricle, the left ventricle up there to the right, and then left atrium, as you all correctly identified. And then just a note for when you're doing bedside echoes or cardiac ultrasound, that make sure that your ultrasound is oriented such that the probe marker appears on the right side of the ultrasound screen itself. And so as you can see in this image, the probe, or the little V, is on the right side, and that's how we identified all of these chambers. And then for some of our senior residents, when you are in the ICU and doing more of these bedside echoes, a quick hint at the RV function is not to look at how it squeezes as if we were looking at the LV, but instead to look at what's called a TAPSE, which is essentially this point of the RV and seeing how much excursion it has up and down. And for a robust RV function, it should have pretty good amount of function up and down, because the RV, instead of squeezing inward like the LV typically does, it actually contracts up and down as if a cylinder would contract up and down. Great. So let's get started with our case. So today we're talking about Mr. V. He's a 63-year-old man. He is presenting with worsening dyspnea on exertion. And so, as with most of my cases, instead of giving you a ton of information up front, I like to come up with a differential. And so let's just build a fairly broad differential for progressive dyspnea on exertion, and you guys can either put in disease processes themselves or big buckets of systems, things like that. ILD, since we know we're talking about ILD today. Yep, absolutely. Cardiovascular, seeing a few heart failures. Mhm. Great. So now we're seeing some non cardiopulmonary things popping up. Somebody said anemia, which is right. Progressive anemia can cause worsening dyspnea, especially on exertion. But mostly it looks like we're sticking to the cardiovascular system. And you guys are right. It's mostly these systems that um, does cause progressive dyspnea on exertion and heme otherwise. And then just anatomically, you know, sometimes cancers can cause it. So malignancy in the chest that's enlarging, nephrotic syndrome. Yeah, absolutely. If nephrotic syndrome is leading to some pulmonary edema and overall weight gain with water weight. Awesome, good work. So let me give you more information about this person. He has a history of coronary artery disease, had a PCI remotely, some GERD, hyperlipidemia, history of spinal surgery, nothing recently. Both his parents died and had lung cancer from smoking. He himself has an extensive smoking history and currently continues to smoke 5 cigarettes per day, but he denies any heavy drinking and no recreational drug use. Most specifically for these patients, it'd be helpful to ask if they use intranasal cocaine or methamphetamines that are inhaled, since both of those can cause lung injury. And then his medications are as expected for somebody with his diseases. He is on statin, he's on metoprolol succinate, and then he's on aspirin, 81 milligrams. And I will give you the exam, and I've highlighted some of the things that are abnormal for this patient. So on his vitals, the most notable thing is that he is satting in the low 90s on 4 liters of nasal cannula. He previously has not had any oxygen requirements at home that he knows about. He's a normal weight person. His head neck exam are normal. He does have a systolic murmur in the right upper sternal border, but no JVD. So his right atrial pressure is normal. He does have some crackles in his lungs, and he's dyspneic on ambulation, but no wheezing. He does have clubbing on exam on his fingers. But you do a pretty thorough joint and skin exam and find that he has no rashes, no evidence of synovitis, and no large muscle tenderness. And so my goal with these case conferences is to help you build illness scripts. And so sometimes it can seem like I'm giving you all the information up front, but it's helpful to recognize that there's a reason I'm giving you this information. And so most specifically, we'll talk about why we did a thorough skin and joint exam for this patient. Great. So the question is, based on that history and that exam, what one test do you want? And I want you guys to start thinking about some high value care and doing tests that are really going to change management. These are some great answers, and I will admit that that many of these could be right, and I think different senior residents and different attendings would choose different answers. And I think a couple of these are absolutely right. So the answer that I had picked for you guys, and we can talk about why, is a chest X-ray. And so the reason to start with an X-ray, even when suspicion for ILD is high, as it is in this patient, and you know that you're most likely going to end up getting a CT chest, is to make sure that we aren't obviously missing something or something that we can act upon more quickly. So for example, if this person, say, ends up having heart failure and some of his exam findings are red herrings, or he has huge pleural effusion on one side, you may still end up getting a chest CT, but it's helpful just to rule out some of the more obvious things with a chest x-ray and starting there. And so I would advocate for you to just get a chest x-ray and see what you see in there. If this person's super hyperinflated, then you may think, oh, well, perhaps I was wrong about the diagnosis of ILD and have to think more in lines of COPD. And then my next test may not be a CT scan, but PFTs like some other people suggested. So here, let's start with a chest x-ray, and you guys will get your CT chest later, because like I said, you're gonna get it in this person. And so I'm going to give you two x-rays. This x-ray was from about a decade ago, if not more, for when he came in for his PCI. And that's his chest x-ray from then. And here's his chest x-ray from now. And so if there's somebody that has a mic available and would like to walk through our new x-ray, I'll wait about 20-30 seconds. Otherwise, I can go through it with you. So cool. So if I were to read these chest x-rays, the left side chest x-ray looks grossly pretty normal. You can see the diaphragms pretty well. No signs of effusions there. His cardiomediastinum looks fairly normal. I don't see any cardiomegaly there. And then otherwise the lung parenchyma looks clear as well. And so the left side x-ray is normal. When compared to the right side x-ray, now we are finding that the heart border is obscured, the diaphragms are obscured. So it would be difficult to say whether this person has effusions or not, because I can't clearly see the diaphragms, though I am not seeing a very clear meniscus either, except for this faint finding here. And then overall, my impression of this x-ray is that he has a lot of reticulonodular pattern on this x-ray. As you guys can see, there's sort of these fine lines, wispy reticular pattern, little bit of areas that may appear like nodules, but this is a reticulonodular pattern, more consistent with an interstitial pattern as opposed to an alveolar pattern. And so I'm not seeing a lot of alveolar filling pattern in this x-ray. And then just the one last thing is that he has some spinal hardware in place, but otherwise no lines or other devices. Okay, so more in line with our diagnosis that we're thinking already, which is ILD. Great. And so now the next best test, I'm not asking you the question because you guys have already told me a few of the tests that you want anyway. And then for the person that wanted an ABG, I don't think that's a bad idea. You could get it, but for this patient, since he is satting well on some amount of oxygen, we have found that we are able to overcome his hypoxia with oxygenation. And so you could consider getting an ABG off oxygen, but it's just going to show you a low PaO2. And now with the correction, his PaO2 is likely normalized because he's satting okay. The reason to get a ABG in this person is whether you wanted to look at his CO2, and that wouldn't be unreasonable. He is not having any obvious signs of retention. His respiratory rate was normal and he's not having any wheezing. He had normal air movement, so the likelihood that he's retaining CO2 would be lower in him. So now the next best test that we should get with that X-ray is, as somebody mentioned earlier, are PFTs. And so let's take a little detour into PFTs. As you guys know, The most common test we think of when we think about PFTs, or some people equate PFTs, is spirometry. But remember that pulmonary function tests are a multitude of tests, and most typically consists of the top 3, but the bottom 2 are also part of pulmonary function tests. And so PFTs comprise of spirometry, which are the flow volume loops, lung volumes, which are sort of part with spirometry, and then the diffusion capacity, or DLCO. And then some of the bottom 2 stuff is more advanced pulm that we're not going to go into today. And then hopefully some of you have, some of our interns have gotten to look at some PFTs report for their patients, but I'm sure the seniors have had a chance to see a few of these in their career so far. And so you get a pretty extensive report based on all the testing that was done. We still currently use sex and race-based data to get the normal values, and are considering moving away from that, but we still use that stuff to get the normal values. And then they'll give you your lung volumes, pre and post bronchodilators. They'll give you your spirometry loops, and then DLCO if part of the exam if that was done. And then I put this up for you guys because I think it is important for us to be able to look at flow volume loops and identify a process that may be ongoing. So feel free to take pictures of these with your phone if you need to, but I think it's helpful to just look at these and see what you would see. The image will always give you what a person's normal is supposed to look like and will label it for you. And so just look at the normal, and then the abnormal version will be underneath it somewhere, and you can compare what it looks like. So next thing to move on to once you look at the flow volume loop is the numbers themselves. And so I want to ask you guys, what is the first value that you look at when you're reading spirometry results? So you guys are close, but none of these are still the correct answer. There you go. So yeah, good. Whoever said that how long the breath was, at least 6 seconds, is absolutely right. So I didn't want to trick people with this question, but of course the first thing you should look at is A, the flow volume loop, and B, the respiratory therapists who do these exams at the bottom will usually state how well the person did during the exam, and if they were able to follow all of their commands and requests or not. And so make sure that that was a good test that you're looking at. And then once you've ensured that it's a good test, the correct answer for this is FEV1 to FVC ratio. So you should start reading your spirometry results by looking at the ratio first. And so I'll walk you guys through how we read spirometry results. Okay, so here are the spirometry results for our patient. And so, like I said, I like to look at the flow volume loop first and sort of remind myself what I think it may end up being, and then try to rule in or out my hypothesis. So for this person, the dots are where the normal numbers are. And then his graph just basically looks like the whole thing shrunk, right? So if we go back to this, here's the normal, and his looks like everything shrunk. So in my eyes, it's sort of either this picture, which does look like it's all shrunk up, or it's restrictive disease, where it's also sort of this tall and narrow graph. So, okay, so I've told myself it's probably one of those two. I think because also his inspiratory loop has sort of narrowed along with his expiratory loop, I'm more leaning toward restrictive disease, and I already have other information like his chest x-ray, which is leading me to an answer. And so the first thing I asked you to look at was the FEV1 to FVC ratio. So here, if you look at the ratio, the predicted number is 76, But in this patient, he's doing better than his predicted, and so his number was actually 82. And so his FEV1 to FVC ratio is normal. Okay, you, for this patient, can essentially stop there, but the fact that it's a normal ratio means that this is not an obstructive process. Because remember, in obstructive processes, the FEV1 to FVC ratio should be less than 0.7. His is more than 100. So then the next thing you look at is, you guys are right, are the FVC and FEV1. And you can look at that in whatever order you'd want. For an obstructive person, you should probably look at the FEV1 next. But for this patient, since we know he doesn't have obstruction, we can look at either of those. And so for this patient, the predicted numbers are way, way higher than what his numbers are. Very poor there. And so those are both low. And then the next thing to look at is total lung capacity, and in him, total lung capacity is also decreased. And then the last thing to look at is his DLCO, which is very markedly decreased, so only 16. And so this is his pattern of PFTs, and it's pretty consistent with a restrictive process. In a restrictive process, typically your FEV1 to FVC ratio will be normal. Your FEV1 and FVC will both be decreased, and typically they're decreased evenly, which is why the ratio ends up being normal. And then total lung capacity is also reduced, and your DLCO is of course reduced. Okay. So we are seeing restrictive pattern on spirometry. And so I'm going to ask you guys to think about a broad differential for restrictive pattern. Great. We're outside the lung already. Nice work. Great. Yep. So I'm glad that you guys are thinking broadly, because I did want to make sure that we were including things like obesity, neuromuscular disorders, all of which will cause restrictive pattern on spirometry. Okay, yeah. Mm-hmm. How about a patient that may have rheumatoid arthritis and is on methotrexate, patient that has atrial fibrillation, is on amiodarone? So medications can also cause this type of lung disease, right? And will cause a restrictive pattern on spirometry. So remember to look through their med list. Yeah, but you guys did a good job. So essentially, the big categories here are the restrictive pattern spirometry is either a process in the lungs, so it's going to be our diffuse parenchymal lung diseases or ILDs. It's either outside the lungs by way of not allowing good expansion of the lungs, and so that's our obesity, compartment syndrome, some of our neuromuscular disorders, and then medications, which also sort of count in the ILD, but I want you to remember that as a separate category. So then, when we take a decreased DLCO, which differentials can we eliminate? Yeah, good. What else? Beautiful. Yep. So remember, spirometry and DLCO are separate parts of the pulmonary function test. So I don't know what thoracic insufficiency syndrome is, I'll be honest. So I'll look that up after. But remember that within pulmonary function tests, spirometry and DLCO are separated, right? So if spirometry shows a restrictive process, the next step is to look at DLCO to see if that's decreased. And if that's decreased, you know you're dealing with something that's going on in the lungs. that's causing infiltration in the septum, that's causing vessel hypertrophy, and is not allowing sufficient diffusion of oxygen across the gradient. And in neuromuscular disorders and things like OHS, that barrier is normal, and so there should be normal diffusion. And so in this patient, because he also had to decrease DLCO, now we know that he has a primary lung process going on. So I just wanted to put this up here as a more sort of way to think about how to interpret PFTs. Feel free to take a picture of this as well. Sometimes I find it helpful, but the more times you force yourself to read the results, the easier it will get. And then just remember to start with the FEV1 to FVC ratio, and right away you'll be able to differentiate between an obstructive pattern versus a restrictive or normal pattern, and then just go down from there. Okay, so far, what we know is that this is a 63-year-old person presenting with dyspnea on exertion. He was found to be hypoxic. He has clubbing on exam. His chest X-ray is reticular interstitial infiltrates, and his PFTs have a restrictive pattern, decreased lung volumes, and decreased DLCO. And all of this, I'm putting a picture together for you to create an illness script for interstitial lung disease. And so let's see if this works, but this is that patient CT scan, and it's gonna run a few times here for you guys. And I will try and pause it to where I can show you some findings here. So in him, we're seeing some traction bronchiectasis. So as the CT runs a few times, you'll notice that he has these bronchi that are looking like they're getting pulled all the way to the periphery, and he has some pretty wide airways that are going all the way out, which is not normal, and airways shouldn't be that open that far into the periphery. So he has some bronchiectasis, he has some ground glass, and then I know this isn't a great image, but the radiologist also called some mild honeycombing on this side. Okay, so he has disease located mostly in the bases of the lungs. His apices are fairly spared. It's bilateral, it's patchy, and he has some bronchiectasis with it. Okay, so we already know that we're dealing with interstitial lung disease. And so I wanted to give you guys a way to think about these. And so because there are so many diseases within this process, in my mind, all of this kept getting jumbled, but I like the way this graphic broke it down. So when I think of ILD, I think of three main things: the lymphangiomyomatosis and histiocytosis X. I've never seen, and frankly, PUM should be involved with those, and PUM should be involved with all of these, but I don't know that I'd be able to like pinpoint it was one of those. But the things that I can do when I first see a patient is ask them about a known cause or association. So like I was already going on my soapbox about drug side effects, is making sure that their med list is clean, that you ask about occupational exposures. These are easy things to do. The first box is an easy thing to do. And then the common exposures here will be asbestos and beryllium. And those are the two common ones that cause this type of lung disease. Medications-wise, methotrexate, amiodarone, some others. And then connective tissue diseases are a big one that cause patients to have interstitial lung diseases. So we know that patients with RA can often have ILD, and so RA-ILD would fall into that category. And some of the other lung diseases, lupus and then ANCA vasculitis, also fall under there. And then the third box here are granulomatous diseases, sarcoidosis, HP, and then infections. And then this category that we're going down for this patient are all of these random diseases that we hear about all the time. And the way to think about these is, in my mind, are they smoking related or not? And so smoking related ones are only two, DIP and RBILD. Then if they're not smoking related, Are they acute or subacute in nature? And so if they're newer for the patient, it's acute interstitial pneumonia or it's cryptogenic organizing pneumonia. And then the hardest category are some of these other ones, which are essentially diagnoses of exclusion. But again, like I said, if you suspect ILD, you should get palm involved, and they can help you read a patient's X-ray to help you figure out which of these entities you may be dealing with. And so the last category in my mind is if this is a more chronic process, which it has been for this patient, is IPF, idiopathic pulmonary fibrosis, or NSIP. And so let's talk a little bit more about how we get to these. Before we go into where in the lungs to find these, I'll just give you the labs for this patient, which was mostly to look for other associated diseases. And so most of his labs look normal. Here's the ABG that other person wanted. And just to remind you that it was done on room air, where you see that he is not oxygenating well, which we already knew. And then remember that we have to rule out connective tissue diseases. So if you have a patient that you're working up for ILD, make sure you order serologies to rule out connective tissue disease. And so in this patient, his ANA, his rheumatoid arthritis stuff, and then his ANCAs were all negative. And so even more proof that we're going down that central path of all of these acronyms that we hear all the time. So just to put it even further into context, we know this patient has ILD. We know that it's not related to medications, connective tissue disease, or workplace exposure. We know that it's unlikely to be sarcoid because we didn't see adenopathy. And he doesn't have any other findings of sarcoidosis, and that it's not hypersensitivity pneumonitis. He has no exposures. And then we'll see why it's, again, not HP, because most of those pneumoconioses and hypersensitivity pneumonitis are located in the well-aerated lung zones. And so upper lobe predominance are those infections and your workplace exposures. Central and hilar prominence would be things like your sarcoidosis and then pulmonary edema hemorrhage. But that, of course, can be more diffuse. And then lower lobe predominance are your idiopathic pulmonary fibrosis, your NSIP, COP, or DIP. DIP, which is a desquamative one related to smoking. And so I like to go back to this picture often when I find myself going down the ILD path when there's lots of things that can be happening, and then looking at the lung zones and seeing which lung zone I'm in. And so in this patient, we saw that his disease was lower lobe predominant, and it was not related to smoking. So I don't think it's DIP or RB, or well, I don't know that it's unrelated to smoking. So we have to ask him to quit those 5 cigarettes, make sure he's completely done with smoking, see what his course does. And then otherwise, essentially what we ended up doing was talking to Palm, like I've been saying, and with their expertise and looking at the pattern of CT scan imaging, they helped us identify that this patient has a usual interstitial pattern and therefore most likely had idiopathic pulmonary fibrosis. And so once you are within any of these categories, once you're sort of down here at the bottom, that's when Palm can look at the CT scan for you and help you identify, oh, well, this pattern looks like usual interstitial. This pattern looks like COP. This pattern looks like NSIP. And they can look at the pattern and help you identify the disease process that you're dealing with. So just to give you sort of the bottom line of the way to go about diagnosing a patient like this is first, of course, your history exam and then a baseline X-ray, like I said, for high value care, and making sure that you're not missing some obvious thing that you're going to find on X-ray. The next step, hopefully in the outpatient setting, but once a patient discharges, if they've already been admitted, are PFTs. And then with those 2 things, you should have good enough suspicion for interstitial lung disease or diffuse parenchymal lung disease, DPLD, that I think the next step involves essentially a trifecta of a high-res CT scan, as you already wanted, some labs to rule out things we can rule out with labs, like connective tissue diseases. And then a palm consult is helpful early on in these diseases because, like I said, they can help you identify the pattern and figure out where to take your care from there. And then sometimes palm will say, okay, we feel pretty confident of the diagnosis just by imaging alone, and then we don't need to do further workup. But sometimes they say, well, we're not sure, we got to do more workup, so the next step is a bronchoscopy. And then from a bronchoscopy, you ask yourself, well, am I confident of the diagnosis now? And whether you are or aren't. And then the last step is a biopsy, which can help you with a definitive diagnosis. And so, like I said, for this patient, it was really our palm colleagues that looked at the pattern and helped us identify idiopathic pulmonary fibrosis for this patient. Sometimes usual interstitial pneumonia is interchangeable with IPF, but UIP is just a pattern on CT scan, and it can occur from medications and some other connective tissue diseases. So just remember not to interchange those. And because this patient has no other reason for his illness, we're saying that he has IPF. And then as far as some of the basics of treatment goes, as I promised you guys earlier, is to stop the offending agent. So whether this is exposures, medications, cigarettes, they gotta stop. They should start pulmonary rehab to get their lungs in better shape and to see if we can avoid using higher and higher doses of oxygen. They should use oxygen if needed, and so this person will likely need to be discharged on oxygen because you want to avoid pulmonary hypertension from chronic vasoconstriction in these patients, and so you should put them on oxygen. And then for most UIP and especially exacerbations, we use steroids, but of course long-term steroids have their own side effects, and so it's difficult to treat these illnesses. For autoimmune or NSIP pattern, the typical treatment is immunosuppression. There are some antifibrotic medications which you guys may see patients be on, nintedanib and pirfenidone. The data surrounding these isn't amazing, but I think we try them nonetheless for IPF quite often. And then ultimately lung transplant. And just as we should with ESRD patients, with these patients, you should think of lung transplant early, because if they have a certain degree of pulmonary hypertension or if they debilitate enough from their chronic hypoxia that they aren't good surgical candidates, most typically these patients don't qualify for lung transplant. So just please think about that early. So if they can get it, they should. And so the bottom line is that when you're looking at PFTs, be systematic, look at the flow volume loops, start with the ratio, and then go on to DLCO if need be. For ILDs, again, be systematic and get a pulmonary consult early if you suspect it. And then for treatments, just understand that your patient may not be on certain treatments for ILDs, but these treatments are decided upon by our pulmonary colleagues, and so ask for their help on whether you should continue something, stop something in the hospital, and if patients come in with exacerbation, typically steroids are a go-to to help with exacerbations. Great, so that's all I had for you guys today. Feel free to chat or voice your questions. And then here's a feedback survey. It's only 4 questions. I mean, I think the link was broken last time, but I fixed it for y'all this time, so it should work now. I would love to hear any and all feedback. I do these presentations and case conferences for you guys, so I want to make sure that you're getting the most out of them.